Good morning, everyone. Thanks for joining the conference today. Today I have a case to present, a quite interesting case. He is a 45-year-old gentleman, and he suffered from a motorcycle accident, which is the most common mechanism of trauma in my country. And he had a blunt abdominal trauma, and he had a fast positive at the first hospital a month ago, and he was in shock. So the first hospital did a E-lab on him, and they found bleeding from mesentery and spleen. And they did just stop bleeding from the mesentery and did some splenography. This was a month ago before he came to our hospital. The problem with this gentleman was after the first operation, he still had a persistent sepsis, high fever, respiratory failure, and renal failure. He had to be on hemodialysis all the time for 3 weeks after the first operation. So the doctor from the first community hospital transferred the patient to my hospital in Bangkok for management. And they did some imaging on this patient after the surgery. Actually, they had first CT scan on admission before they went to do the E-lab on him. And retrospectively, the radiologist reported possible transection of the neck of the pancreas, which they did not address on the first operation at all. They did not go into the lesser sac and examine the pancreas. They just stopped the bleeding from the mesentery and the spleen. And 3 weeks later, after the patient developed sepsis, renal failure, respiratory failure, they repeated the CT scan and they found like a big collection in the lesser sac and obviously transected pancreas at the neck. A month after first surgery, he was transferred to my hospital in Bangkok. Airway, he was intubated. The tube was okay. Breathing was okay. He had a bilateral breath sound. Circulation, he had been on norepinephrine to maintain his blood pressure from the first hospital. And he had diffuse abdominal tenderness. He was awake and alert and followed commands, and he was febrile. Labs on my hospital, we found anemia, leukocytosis, and azotemia, and he had some acidosis with a serum base of 172. And we repeated the CT scan. This was 4 weeks after the first operation. Now we can see air fluid collection in the lesser sac. The big one, as you can see here. This imaging, I did not put the contrast in because of his kidney. So this is all the information we had at that time. I would like to ask the group about the next management for this patient. Gary, could you please moderate for me, please?
Absolutely. Dr. Alex in Philadelphia, your comments, please.
Morning, can you hear me?
Yes, sir. Loud and clear.
So it looks like there's definitely an abscess going on over there, and probably related to the pancreatic ductal injury. I would start with broad spectrum antibiotics. I would reach out to interventional radiology to put a big drain and remove all that infection. And also moving forward, I would consider a MRCP just to get more information, more imaging. The other option would be to take into the operating room and wash out all this, but I think a more less aggressive approach with the drain and antibiotics until his physiology improves before more surgery if this doesn't help. I would start with that. Thank you.
Thank you, Dr. Alex. Let's go to Baghdad for Dr. Rabin.
Yes, is the patient hemodynamically stable and metabolically stable?
he
Can
had
you
been
hear me?
on norepinephrine to maintain his blood pressure, but his blood pressure was okay at that time. He was on respirator and oxygenating well, but he had no urine output and he had been on dialysis for a month.
Yeah, I would give strong consideration to going to laparotomy with distal pancreatectomy and draining the sepsis.
Thank you, sir. Let's go to Dr. Calderon, Peru. Lima, Peru, actually.
Yes, good morning. Yes, this patient is not stable. He is very sick. I wonder if he could tolerate a trip to the OR. I agree. I can, if I have the availability of an interventional radiologist to place percutaneous drainage of this big abscess that maybe took place because he has the pancreatic duct injury, to allow to a good drainage of this big infected collection. Well, instead of an MRCP, I would try to get hold on GI to make an ERCP, not only for the imaging, also to have to allow a better drainage of the biliary and pancreatic duct. And I hope it works, if just for a beginning. If it doesn't work, or if I don't have the availability of these units, I would take the patient to the OR, but the patient needs the drainage of this big abscess. Thank you.
Thank you, Dr. Calderon. Dr. Lawrence, your comments, ma'am.
Yeah, I agree he needs to be drained. I just get concerned at this stage. I agree with whether or not he'd tolerate anesthesia. And would you be going into a hostile abdomen 1 month out? But he needs to be drained. I think it would be prudent to try to see if interventional radiology could put in a drain, but then you're still stuck with possibly a transected pancreatic duct. So I think getting them to a point where he was more stable and do it possibly in a staged kind of procedure with interventional draining it, and then going back and doing your ERCP and imaging if you could, but he needs to be drained either way.
Thank you, Dr. Lawrence. Let's go over to Boston, Dr. Bawazir.
Yes, sir.
I go for Boston. Dr. Bawazir will go the next time, if that's okay with you, Gary.
You're the man.
No, it's his first time in this conference, so he doesn't know the format. I'm sure that
fine.
he can do this, but so a few things here. I have to admit that I don't think I ever got a patient with a transected pancreas 1 month later. Here, the patient will get transferred much sooner, and I admit my lack of experience with dealing with this 1 month after the diagnosis essentially was made at that time. During all these years, I always have also have to emphasize the difference between a trauma to the pancreas and traumatic pancreatitis, which is really a misnomer. This patient has a trauma to the pancreas, the pancreatic enzymes will be elevated. Traumatic pancreatitis itself is extremely rare, the same way that we don't call traumatic hepatitis when the patient has a liver trauma and the liver enzymes are elevated. So trauma to the pancreas is trauma to the pancreas, is not pancreatitis. However, this patient, after several weeks or months after this, the behavior of this is more similar to a pancreatitis than a trauma. And the image that we can see here with our IV contrast is very similar to the image that you will see in a patient with a complicated necrotizing pancreatitis. I do not know what happened to the distal end of the pancreas because it's not done with IV contrast. I don't know if it's still perfused or not. Backtracking a little bit, this patient, when you suspect injury to the neck of the pancreas, needs to be explored, and if confirmed, this distal pancreatectomy plus minus splenectomy, which in this particular case, if the patient already had an injury to the spleen, it would probably have been with a splenectomy. So, but now you have this, which is very similar to what you will see in a necrotizing pancreatitis, which is infected. I think you need to, the thing that we can extrapolate is from that, and I think we need to treat that as an infected necrotizing pancreatitis. MRCP might give us some extra information, but it would not change the management. I think this patient needs to go to the operating room. And why? I know the literature that they say that percutaneous drainage and drainage with lavage and surgery, they are all similar. In my experience, that's not the case. This pancreatic necrosis, because this patient is leaking pancreatic fluid in the retroperitoneum, which is causing necrosis of fat and other things in the retroperitoneum, is very, very thick, has a consistency of cheese rather than fluid. And that's the reason you see all those pockets of air. So the percutaneous drain, you can try, in my experience, never works. The best thing to do 1 month later, I will take this patient to the OR and do a necrosectomy, which I imagine that this is what he has there, and probably leave the abdomen open, because most likely than not, I would need to come back for further cleanups over the next few days. Thank you.
Thank you, Dr. Oyman. Let's go back to Baghdad. Dr. Untrat. Go ahead, Dr. Untrat. Okay. Is my audio coming through, folks?
Yes, Gary, we can hear you.
Okay, Dr. Untrat, we'll come back to you on the next round. If anyone's in contact with him, go ahead and let him know he can't hear us. Let's, Dr. Bawazir, would you like to comment before we proceed?
Yeah, so I basically agree with Dr. Hoy, but can you hear me?
Yes, sir, we can hear you. Why don't you go ahead and block your video? I think you're starting to have bandwidth.
Yes, so.
Go ahead. All right.
Okay. So I agree with, I basically agree with all the comments. My training was as Dr. Hoyman described. Usually the necrotic tissue is so thick that certainly in the old days when I trained with Andy Warshaw in Boston, it never worked, and the mortality in those patients that had the percutaneous drainage was higher. And I know the recommendations have changed, but in this case, it's been a month. He has pockets of gas. So I think, certainly he needs to be on broad spectrum antibiotic coverage with anaerobic coverage, and it's reasonable to give it one attempt at percutaneous drainage. But if there isn't a good drainage very quickly, and if he doesn't improve right away, then I think he would need to go to the operating room as soon as possible after that. That sick as he is, he's if he doesn't improve with the minimal procedure, he's not too sick to have a life-saving operation, to do a necrosectomy, distal pancreatectomy, splenectomy, very aggressive drainage, and possibly even leaving the lesser sac open, to pack it open in the ICU.
Thank you, Dr. Untrat. Let's finish up this round with Dr. Bawazir.
I actually agree with what have been said. Seeing gas in the pancreas, this indicates that it's an infected fluid collection and it needs to come out somehow. Percutaneous drainage, I agree with Dr. Hagman, most of the time does not work because of the thick pancreatic tissue. Operative drainage and placement of some drains for continuous irrigation, probably that's the best course of action at this time.
Okay. Thanks, sir. I believe everyone has had a chance to comment. And if that's the case, let's go back to Dr. Suppa.
Thank you, everyone, for your great comments. And in this patient, for the reason that Dr. Hodgman has spoken already, I decided to perform a laparotomy on him because I like to drain the pus and debride the necrotic tissue in the lesser. And I would like to find whether or not there are any missed injury more than the pancreas. So what we found lots of infected hematoma or pus. Like you can see here, like 1 liter of the pus and infected hematoma in the lesser sac. And he didn't have any bowel injury on exploration. But this is the lesser sac and retroperitoneum. He had a necrotizing infection of the lesser sac and the retroperitoneum. I could not identify pancreas from the lesser sac on the first operation. So what I did was just to drain all the infected fluid and infected hematoma and try to debride the infected tissue. I put the Penrose drain in, and I ended up closing him with a white crew mesh to leave the abdomen open. And I put the vacuum dressing on top of the white crew mesh. By doing this, I could avoid abdominal compartment syndrome in this patient. And I believe that to leave the abdomen open with absorbable mesh on, I can still drain the infected fluid and exudate from the vac directly from the abdomen. And I put this patient back to the ICU for resuscitation. Anyway, 13 days after the first operation, he still had persistent sepsis, and he had exudative. He had like a pus coming out from the drain and the white crew mesh. And as you can see, he had the mesh detached from his abdomen. So 13 days after the first operation, I decided to bring him back to the OP. And on the second operation, I removed the mesh and I went into the lesser sac again. He still had loculated pus in the left abdomen, left paracolic gutter, interloop, and in the lesser sac also. So this time, after washing the abdomen, I tried to explore again in the lesser sac. And I still find like necrosis of the retroperitoneal tissue. I thought I saw this tall end of the pancreas, as you can see around here. But at that time, the patient was not quite stable. He required a lot of pressure. So I decided to stop the operation at this time. And I temporarily closed the abdomen, and I planned for the second loop operation or the third operation next 2 days. So at the end of the second operation in my hospital, I closed him temporarily with a vacuum pack closure. So the next question to the group is, what is the plan for the next operation?
Dr. Untrat, your comments, please.
Yes, so at the operation, you took out the spleen and whatever tissue was there, just scooped it all out. The lesser sac is cleaned out. And you didn't see the head of the pancreas and the duodenal loop at all?
Duodenal loop was okay. Nothing's wrong with the duodenum. And the tail of the pancreas, I think around here.
Oh, around there, but and you didn't try to take it out. You just drained everything. Well, I guess, but before this last operation, I would have gone back to CT to see if there are any undrained collections. But so there's still a source of infection, presumably coming from the lesser sac, and I might consider this time, because he's not getting well, there's still a source of infection, to remove the spleen, remove the tail of the pancreas, and basically remove all of the infected tissue in the lesser sac and then pack it open. So, and you can actually change the packings at the bedside in the ICU, just sort of an open lesser sac. In the old days, we used to do this basically with a lot of drains. So what we call cigar drains is stuff, the Penrose drain with gauzes, and then sump drains, and you have so many of them that it's an open abdomen. But the other way is to just pack the lesser sac open, and then it's just an open wound with the rest of the abdomen closed off. But I agree, this is kind of a more difficult situation.
Yeah, we just lost your audio, Dr. Untracked. You muted yourself.
Oh, sorry.
Okay.
If there's, anyway, so I think I would consider just very aggressively cleaning out the any infected fascia and the lesser sac, removing the spleen, any necrotic tissue, and then pack the lesser sac open. And also the cultures, what the organisms that you grew, I assume that he's on the appropriate antibiotics to cover the organisms that are growing. But I would certainly be sure that he has appropriate antibiotic coverage.
Thank you, Dr. Untracked. We're getting a lot of background noise. So folks, just as a friendly reminder, if you could please mute your mics until you're ready to speak. Thank you. And with that, we'll go to stay in Baghdad with Dr. Lawrence, please.
These injuries are tough. And I recall years ago, a patient that was transferred to our hospital into our ICU with a missed pancreatic injury. And he went in for exploratory laparotomy and necrosectomy, and we did a bunch, but mainly when we got to this point where he kept representing like this, it was an open abdomen in the ICU with twice a day dressing changes. And the antibiotics were adjusted to whatever he was. By that time, he had developed everything. He was colonized for everything that was in the ICU. So it was hard to tell, but he did remain on dialysis. He did not survive, but he lived for 6 weeks like this. That's all I have. I mean, the only thing I know is drainage, necrosectomy, get it all out, and second look and go back daily and check. And I really haven't seen something like this survive.
Thank you, Dr. Lawrence. Let's hop over to Dr. Hoyman, Boston.
This is a nightmare because there are really no good options here. The good options, the train left the station a month ago with the good options. So in the initial surgery, you remove everything you can, and usually when you go back, you will find more necrosis that you need to debride. The problem here is that you still have pancreas, which you have two problems with the pancreas. One, you have the head of the pancreas with the duct transected that it might close or might not close. Probably not. Normally during the index operation, if you do it on time, you close it yourself. So now what this patient will need will be an endoscopy with a stent in the remaining of the pancreas, trying to decrease the pressure in the proximal pancreas, not to have a backward leak into that area. I don't think you will find a GI physician who will be willing to do this, but you can try. And the other part is that the distal pancreas, it could be partially alive and partially making more pancreatic enzymes, causing more necrosis after you remove the necrotic tissue. And trying to do a distal pancreatectomy at this time is, I would say, it's impossible. I don't know, maybe a better surgeon than myself can do it. I don't think I would be able to do it. It's reasonable to try, but essentially you cannot get source control until you remove the offending tissue causing the problem. So I would try to remove, this patient will need multiple operations, necrosectomies and removal of the pus and everything. I will have to find a way to leave the abdomen open. Again, this is very unusual to see nowadays because patients get transferred much faster. I really, Dr. Supa, I commend you for being willing to take these patients after a month. Fortunately, that doesn't happen to us here. But I remember, as Dr. Untracked said, in the old times, when I was a medical student, they were doing this open, the marsupialization of the retroperitoneum between the colon and the stomach and leaving that part of the abdomen open for months. But they didn't end up well, those patients. Those were disasters. That's the reason that type of surgery was abandoned. But maybe that's the only option for this patient, doing something like that, leaving part of the abdomen open with marsupialization of the retroperitoneum, because I don't think that you can get out the distal pancreas at this time.
Thank you, Dr. Hoyman. Let's go down to Peru. Dr. Calderon.
Yes, I agree that the patient needed an earlier transfer, but we already have the problem in our hands. So, well, with a good debridement, the appropriate antibiotics, while you are leaving the abdomen open, he will need re-explorations at least every day or every 48 hours. Well, you need to continue cleaning up the abdomen or retroperitoneum. I don't know if you can make the distal pancreatectomy because that's all stock with additions. And if you can remove the distal pancreas, that will be very difficult to close the pancreatic duct stump. It will continue leaking pancreatic fluid. I also was thinking about insisting with VI to do the ERCP with sphincterotomy or stenting to allow the drainage of the pancreatic fluid, because I think that this is an abscess secondary to the leakage from the pancreatic lesion. So, well, that's I don't know what else to add to the other comments. Yes, every 1 or 2 days, continue new re-explorations with washouts and try to do the drainage of the pancreas through ERCP. I insisting with that, and well, all the continuous resuscitation you're doing. I don't know if the patient needs dialysis because he's having acute kidney injury, or I don't know if he has renal failure. Well, that's all I have by now.
Okay. Thank you, Dr. Calderon. Let's, Dr. Ribbing, your comments, please. You're muted, sir. Check your mute button, please. Yeah, you're still muted. Look down on your Zoom screen, lower left-hand corner. Yeah, sir, if you don't mind, we'll let Dr. Alex go ahead and go. Once you find the mute, just go ahead and leave it open. Go ahead, Dr. Alex.
Wow, this is not easy here. I think, with my first initial management, with going with a drain, get more imaging, I think that would maybe have made GI more amenable to attempting to do an ERCP and maybe put a stent in control pancreatic leakage from the head of the pancreas. But right now, the abdomen is open, and I would like to make sure that he doesn't have any other sources of infection. For whatever's worth, I would consider just re-imaging with oral contrast, make sure nothing is leaking anywhere from all that infection that may have eroded into portion of the bowel or not. Nutrition wise, he would definitely need the heavy nutrition support via TPN. I'm curious if he has any endocrine function, if he requires any insulin, if he's holding on his own. In terms of going back to the operating room, if the CT scan shows no viscous injury, nothing to entertain the infection, then continue to wash and hopefully debride that distal portion of the pancreas that's maybe contributing to the infection. I would not close the belly. I would do only like a couple of washouts, and then maybe leave some big Mallet drains to kind of irrigate and just suction out to minimize the number of trips to the OR and go from there. Thank you.
Thank you, Dr. Alex. Dr. Ribbing, looks like you have your mic situation good. Let's like to hear what you have to say, please.
Yes, I agree with a lot of the comments. I think, as usual, you have to look for the underlying specific cause of the problem. And the problem is persistent pancreatic leakage. and you have leakage from the head of the pancreas and from the tail of the pancreas. And so I think endoscopic stent placement is a good start in draining the pancreatic duct in the head. I think that, you know, if it's technically at all possible, and that's the call that they will only be made by the surgeon at the time of surgery, then I would do the distal pancreatectomy and splenectomy, although it would be exceptionally difficult and bloody. I think that the ultimate problem there is going to require that. The chances of that fistula healing are small. If that's not possible technically, then I think your only other option is to do what the other speakers have suggested, and that is open packing and treat it as if we were treating infected necrotizing pancreatitis years ago.
All right, thank you, sir. And didn't forget about Dr. Bawazir back in Boston. Your comments, please.
Yes. So this is a very difficult problem, and I agree with the group. The patient is not going to get better unless all the infected, excuse me, unless all the infected necrotic tissue is coming out. So either we bring him back every couple of days for continuous washout and removal of all the infected tissue. The other option, I might have mentioned that during my first comment, is placing what I've seen and done before, placing some drains behind the stomach and to give continuous irrigation in the ICU. That's gonna make the trips to the OR probably less. Resection of anything at this time, doing distal pancreatectomy or splenectomy, I don't think I will be able to do it with the amount of inflammation at this time. Thank you.
Thank you. And let's see, there's someone that Dr. Gutierrez, did you want to comment, please? Dr. Edgar Gutierrez, would you like to comment? All right. Has everyone had an opportunity to comment that would like to comment before we return to Dr. Suppa?
Yes, Gary, may I?
Oh, I'm sorry, Dr. Calderon. I know I was missing someone. Yes, sir,
I want
please,
to
go ahead.
something. Yes, the last comments of the colleagues remind me something, because I was going to speak about the drains. I would never use a Penrose drain, especially in pancreas. If I don't, I would use a JP, or you mentioned, Dr. Alex, the use of Mallinckrodt. If I don't have a Mallinckrodt, I would use a thick tube. Sometimes I made up tubular drain with the rectal tubes. Big is thick. I would place two, one for irrigation, the other for allowing the drainage, continuous drainage. That's it. Thank you.
I'm sorry, I was thinking Duval drain, but I said Mallinckrodt, Duval drains. Sorry.
All right. Thank you very much, sir.
Oh, okay. Thanks.
All right. Okay, let's go back to, let's go ahead and proceed. Go back to Dr. Suppa, please.
Thank you guys for your great comments. So I had been thinking about what to do for 2 days, and I went ahead and did the distal pancreatectomy and splenectomy to try to get rid of the viable pancreas, to decrease the pancreatic juice leaking into the lesser sac. So the infection looked better at that time. He had less pus in the abdomen, and here this is the distal pancreas. Proximal pancreatic stump was around here, and this is the distal pancreas. So anyhow, I managed to remove the distal pancreas and the spleen out, not together. I removed them separately, but put them together to take a picture. So it would be easier for you to understand. This is the pancreas and this is the spleen. And I washed the abdomen out one last time. And again, I decided to put the Penrose drain in. This time I put 1 JP in the lesser sac too. And I closed the abdomen with a white cream mesh. What happened to him next? He still had a persistent fever, and we put some drain in the left chest and in the abdomen. So 29 days after the first operation in my hospital, he had bleeding from the Penrose drain and the percutaneous drain also. And he dropped his hematocrit. That time, we brought the patient to the CT scan, and his kidney was getting better at that time. But anyway, we had to put the IV contrast in to check for blush, and we found a blush in the lesser sac. So I called the IR guys. They came in and they tried to do some angiography. They did not find any active extravasation from the branch of the celiac axis and SMA. Anyway, I asked them to prophylactically embolize the splenic artery stump. At on the last operation, I could not identify any split vessel. I just removed the pancreatic tissue. And my thought at that time, he may have pseudoaneurysm of the splenic artery that we could not see. So I asked them to embolize the splenic artery, and they did. Unfortunately, the bleeding continued from the Penrose drain, from the percutaneous drain, and this time from the NG tube. And he was tachycardic, and he dropped his hematocrit, requiring lots of transfusion. I think this would be the last question to the group. What should I do at this point?
All right. Dr. Calderon, can we start with you, sir?
Dr. Suppa, this is a nightmare. This is the problem with the leakage from the pancreatic fluid. Well, the pancreas bleeds itself, the splenic vessels can bleed, and the pancreatic fluid erodes the tissue around. It can be bleeding from the mesenterium, from the retroperitoneum. I don't know if the patient is coagulopathic. Well, you're already giving a transfusion to the patient, but you don't have, in this situation, you don't have more option than explore the patients, open up the retroperitoneum, look if there is some bleeding that you can stop by any surgical means you can. Or maybe, well, it's just leaking, it's just bleeding from all the wall, but you have to take a direct look and try to stop it directly. If you can, just to do compressions, just to pack the retroperitoneum. Well, and take a look at, we already told us that he has an abscess below the diaphragm, did you? Well, you have to look around the whole abdomen if there is any other source of contamination or bleeding. Well, just you start from that and good luck. This seldom happens with trauma. We see these kind of things usually in the worst cases of pancreatitis. So this is very tough. I wonder, Dr. Suppa, allow me the question, please. How did you close the stump of the pancreas?
The proximal pancreatic stump, I didn't do anything. The tissue was friable, and there was no bleeding, no active pancreatic leaking that I could see at that time. So the proximal part, I left alone. I just removed the distal part.
Oh, well, that would be very frail also. Okay, thank you, Dr. That's all I have.
Thank you, Dr. Calderon. Let's go to Dr. Ribby. Baghdad, please.
Yeah, I think with the difficulty in doing any type of suture ligation of the pancreatic duct at the head of the pancreas would be very difficult. Just as was mentioned, is that you're going to have a very friable tissue, and putting any sutures in there aren't going to hold. And if they do, it's going to fail anyway. And you've done arteriographic embolization, and but you still have persistent bleeding. You don't know where that bleeding is. The patient's been in, I understand, renal failure. but the bleeding represents a real threat to him. And I would consider probably doing a repeat angiogram and embolize anything that might be bleeding still. Otherwise, I would the only other real option here is to go back in and just pack it. And just go through the process again as how we used to manage necrotizing pancreatitis with the complication of bleeding, which was an increased complication with repeated debridements in the open abdomen. But I think that those are really your two options now.
Thank you very much. Let's go to Dr. Bawazir, please.
Yes, sir. So this, as everyone said, this is a difficult situation. This is exactly why I said before, resection is probably not, to me at least, not a good choice because of the friability of the tissue. And now he's pre-bleeding from all the friable tissues in the retroperitoneum. First of all, I would like to see if the patient is coagulopathic or not. Make sure that there's adequate platelets, INR is corrected, and resuscitate the patient. Consider doing another angiogram with my interventional radiology colleagues. If radiology is not an option, eventually he needs to go back to the OR for re-exploration and pack the retroperitoneum. Thank you.
Thank you very much. Dr. Lawrence, your comments, man. Go ahead, Dr.
Hello,
Lawrence.
yeah, this is a nightmare. Hi. So, yeah, I mean, you know, you know, when I see bleeding continuous from everywhere and they're on dialysis, it's hard to get on top of that coagulopathy. You know, you could get a DIC panel, but now you're asking yourself, is this surgical bleeding that I can go in and control? Or is this something with, has he gone into DIC? I pursue, you know, working him up for any kind of coagulopathy, trying to correct that. At this point, another surgery, yeah, I mean, and packing's good and going back in, maybe angio would be the answer if you could find someone from interventional radiology that would go in. I mean, I don't have the rest of his numbers, what was he in DIC or what did the rest of his coagulopathy panel look like? I mean, would somebody willing to stick them and try to go back in and angio again?
His bleeding profile at that point was okay. We did the rotem and it was okay. But anyway, we transfused him with a.
You did a tag, a rotem, not a tag.
Yeah.
Okay. So okay, well, gosh, I'd pick one. Maybe I'd be more conservative. And you had, how long ago was the angio? How long ago, how many days before? Was it one day or was it recently?
Yesterday.
The prior embolization.
The day before. Yeah. We did embolization on day 29 and on day 30, he still had continued bleeding.
Yeah, you may have to go back and I get in and out of there real fast if I took him back to surgery. I think I would just pack him and continue the resuscitation if he needed it and see what he did. It's kind of like pick your poison. Sorry, that's just, these are very difficult. They're catastrophic and they're insidious. And once you've missed them, it goes kind of like this, in my opinion.
Thank you, Dr. Lawrence. Dr. Wyman, your comments, please.
Well, in my previous comment, I said that under ideal circumstances, you would do a distal pancreatectomy and probably the splenectomy, but I didn't think I could do it. And I say maybe a better surgeon can, and Dr. Suppa proved me correct. He's a better surgeon and he did it. Congratulations. I thought that would have been impossible. And kudos to you for being able to do something so difficult. Now we're having a different problem. this is a very hostile abdomen to go by. First, where is he bleeding from? Looking at the CT, I didn't think that was going to be the stump of the splenic artery. This looks more posterior. I would think a lumbar, maybe something from the adrenal. It's very posterior. It could be, but the area should be really very difficult to access, except this is the only possibility. So I would try a new angiogram to see if you can see it, because that's the easiest one. But if that doesn't work and you need to go back in, I was thinking this would be very difficult to access that area, except I'm thinking now that maybe the remaining pancreas, the head of the pancreas, the fluid drains through the area of less resistant, which will be in the transected stump, not through the ampulla. So this might be a bunch of necrotic tissue, and this is what usually happens when you have an uncontrolled pancreatitis / pseudocyst, whatever, that all those enzymes are digesting everything, that eventually one of them digests the wall of a vessel and bleeds. So I think in this case you have no option but to go back in. If IR is not an option, it will be a difficult surgery. But you already proved that you can do difficult surgeries. So I think that this tissue is not going to be so dense. It's going to be very similar to the one that you found during the previous surgery. And you might be able to find the bleeder, which appears to be arterial. So you will have to find that venous bleeding can be packed, arterial bleeding, you have to find it. So my gut feeling in this case is that IR was unsuccessful. You took this patient back and you found the bleeding. I don't know. That's all I have. Thank you.
Thank you very much. Dr. Alex, your comments, please. Dr. Untrack, I'm getting to you. Thank you for your patience. Go ahead, Dr. Alex.
It looks like you're not getting a break from this case, Dr. Supa. So with coagulopathy being corrected and another angiogram maybe was done, maybe not, and it's not really helping. The only option is to go back in and control directly the bleeding. The question is, do you go through the midline and disrupt everything that you put back there together, or another incision on the left side, kind of retroperitoneal, to just kind of access that way? The other option would be, I personally seen that described, where your JP can be your friend, where IR can put a bigger drain, access that cavity, and then upsize that with something larger, through which, let's say, for control of infection, you can go in and irrigate and put a camera and just, remove some pus. I don't know if you have a slow venous ooze here that is not obscuring the view. If you went that route, that you may be able to just pack some hemostatic agents, even put a clip or two, or maybe even inject some Flosil or thrombin. So that's all I got. I'm curious to see what you did. So far, you kept him alive, and he was lucky that he was transferred to your hospital.
Thank you, Dr. Alex. Dr. Untrack, thank you for your patience. Your comments, please.
Yeah, so both Dr. Alex and Dr. Oyman mentioned the venous bleeding, and I think if it's not a major arterial branch, the venous bleeding is a likely possibility. So, for example, the splenic vein, which was never identified, could be bleeding from there, or just diffuse capillary and venous bleeding. And looking at that last CT scan, there's still a big undrained collection. My experience with pancreatitis is you need a lot of very large sump drains, and many of them to keep that space evacuated. So in this case, I agree with going back and then evacuating all of that inflamed tissue that's not being drained, and just packing the lesser sac open. So if you don't see any named vessels bleeding, pack it open, tamponade the bleeding, and then keep the lesser sac evacuated of necrotic infected tissue, and just change the dressings if you need to in the ICU with sedation or mild anesthesia. But I think that the key is to keep that lesser sac fully evacuated of that extraneous tissue and fluid. I suspect that's what you did, because unlikely you would see specific bleeding arterial branches, or you're not going to see the splenic vein, but you likely would see a lot of inflamed, infected, oozing tissue if you went back to the OR at this point.
Thank you, Dr. Antrad. Dr. Gutierrez, would you like to comment at this time? You muted. Check your mute, lower left hand. There we go.
Yes, thank you very much for the opportunity for talk back. In this case, I administer hemoderivates and return to the patient surgical room and remove all the tissues and coagulate and put a packing and wait for the patient. But I think that the cause is a little artery for the pancreas in this bigger infection over in the retroperitoneum, and for the vessel like a venous, it's possible that raising this hemorrhage. Thank you.
Thank you very much for your comments, Dr. Gutierrez. Any other comments before we return to Dr. Suppa?
One quick thing.
Yes, sir.
This is going to be a very hostile abdomen, so maybe I will use this. I don't remember who mentioned this, but I will probably use a CT scan to plan the incision, because this area might be better access through a subcostal incision if possible, trying to get straight into that cavity rather than trying to go through the midline, because there might be too many adhesions in that area. So I will use a CT scan to plan my incision. I might have to go through the midline, but that's something to think about in cases like this with a very hostile abdomen.
Thank you, Dr. Hoyman. Okay, let's go back to Dr. Suppa.
Thank you very much, everyone, for your comments. So I ended up performing another operation on this patient. I went directly, I removed the absorbable mesh and went directly into the abdomen. And this time I found a lot of clot in the lesser sac. And luckily I found the source of bleeding. It was 2 holes in the posterior wall of the stomach, around 1.5 centimeter each. So he had bleeding from the perforation of the stomach into the stomach. So he had GI bleeding, and outside the stomach. So he had intra-abdominal bleeding. And the stomach tissue was inflamed at that time. But I didn't have any other option. So I just had to simple closure. I just put some suture with PDS 3O to close these 2 holes. And this is what I learned from Miami. After we performing any anastomosis, we always use fibrin glue to reinforce everything we suture. So I never used fibrin glue for 10 years in Thailand after I came back from Miami. But this time I needed something to help reinforce the suture. So I used fibrin glue on top of the simple suture. And I brought the patient back to the ICU this time. And he was doing quite okay after the 5th operation. I could use the NG tube and feed him and fed him through the NG tube. And the abdominal wound looks better with some granulation. And on the 2nd month, he recovered from sepsis, and he recovered completely from renal failure. He put out a lot of urine, and he didn't require any dialysis. And he tolerated gastric feeding well. Anyway, on day 67, he had fever and abdominal pain, and he had hyperamylasemia. And once we changed the vac, we found lots of saliva from the vac. So basically, I think the stomach suture just opened, and he had a perforation again. We did some CT scan, and this time there was no drainable collection. So at this point, I did NG tube insertion. I consulted my colleague who's good at endoscopy, and she went ahead and she did EGD on this patient. She tried to insufflate the stomach, but she couldn't insufflate the stomach, meaning that there are still some leakage from the stomach. And anyway, she could put the NJ tube through the jejunum. So now I had a postparic feeding, and I continue to feed the patient through the NG tube during the 3rd month. And fortunately, now it's been 4 months already after the injury, and he's doing much better. I removed the NG tube and I let him take oral diet, and he was very happy to eat something through his mouth. He recovered from renal failure and from sepsis. Anyway, he has critical illness, polyneuropathy, and I consulted PT for that condition. He's doing much better, but he had a bilateral wrist drop, as you can see here. He survived all the operations I did. For me, the lesson I learned from this particular patient, this injury can be fatal. So we have to pay attention during trauma laparotomy, especially in a lesser sac and retroperitoneum. And I should have planned for this self-feeding route earlier in such complex injury. And in this patient, I should have closed the abdomen temporarily on the first operation and plan a laparotomy to get rid of sepsis. I should not expect that the sepsis would be controlled by just one operation. And fibrin glue to me does not help a lot. So that's all I have for this patient. I would like to hear some final comments.
Okay, thank you, Dr. Super. Dr. Alex, your final comment, sir.
Thank you for presenting this case. Definitely learned a lot from it. It's really quick to take a look in the lesser sac. Otherwise, you have to deal with all the things that you presented, and I will certainly remember that. For the gastric ulcer that was found and that was bleeding, sometimes our GI colleagues can in some hostile abdomens, I used that in the past where they do an endoscopy and they use this closure device, an Ovesco clip, to control that. Hopefully, that doesn't happen again, but it's an option, and that maybe would have helped this patient. But congratulations on a nice presentation, nicely how you handled the case, and for presenting it to us. Thank you.
Thank you. Dr. Untrack, your final comment, sir?
Yes, well, that is a great save, and just really, this is a case that the mortality in the best of hospitals in the States would have been very, very high, and it's just remarkable. And I think that the points you mentioned, they're, it's good that to try and find things that you could do differently, but still, I think despite that, it's just superbly done. Sometimes like a jejunostomy tube early on, then you can maintain feeding that way. But those are all, I think, minor points. And at the other hospital, maybe had he been brought back sooner, if they didn't explore the lesser sac, bring back sooner, leave some big drains, that might have made the course a little easier. But very, very impressive result. I'm really very, very impressed at the outcome. Terrific job.
Thank you very much, Dr. Untrack. Let's go to Dr. Pawazir.
I would like to congratulate Dr. Sopa on this great save. This is a very difficult injury, difficult problem, and a great job. Thank you for sharing this case with us. I learned a lot from that. And thank you for having me as a first conference.
Thank you for coming, sir. We hope you'll join us on a regular basis, please.
Absolutely, yeah.
All right, thank you. Let's go to Dr. Rebank.
Yes, I would just like to applaud the surgeon for his care of this patient, a very difficult case. And I also agree with his final thoughts, in that early placement of a feeding jejunostomy tube is quite valuable in this situation relative to eliminating the possibility of having to give parenteral nutrition. And then, at least in my practice, I don't use Penrose drains. I just believe in closed suction drains and large drains, and I agree with his comments.
Thank you for your comments, Dr. Vink. Thank you for joining. We hope you'll join us also on a regular basis. Dr. Lawrence, your comments, man. Go ahead, Dr. Lawrence. Okay.
Oh, I'm sorry. It's breaking up. A truly heroic efforts and remarkable save. I mean, this is a great case and great reminders. I mean, I was always taught when you do an exploratory laparotomy, you do an exploratory laparotomy and you open the lesser sac and you explore everything. You know, I don't know how these injuries get missed, and when they do get missed, they do present late and they're often fatal. But this is great, and great reminder about placing early enteral feed. Truly a good case presentation. I enjoyed it, and of course the outcome that's just been it's unremarkable. Like it's remarkable.
Thank you.
Heroic save.
All right. Thank you, Dr. Lawrence. Dr. Gutierrez, your final comments, please.
It was a big challenge because all the patients are different, but the pancreatitis is very strong and the management is so difficult. But my congratulations for the team and for all the participants for this meeting. Thank you very much.
Thank you, Dr. Gutierrez. Dr. Gutierrez, where are you located in the world?
In Marseille, France.
Oh, okay. Very good. Well, thank you for joining us. We hope you'll join us again, and we hope you'll also spread the word about our meeting here.
Okay.
All right. Thank you.
Okay.
And I'm sorry, sir. Go ahead, please. Okay. Let's go to Dr. Hoyman in Boston.
Dr. Supa, this patient should have died many times. And this proves that you are a master surgeon. Congratulations, sir. The only thing is I have two things. One, I don't think you should worry about putting a distal feeding tube. I usually doesn't, in my experience, leads more complications. I just try to do whatever I've been called to do in the OR and get out in these cases. And I have a favor to ask, if you don't mind sending an email to Nikolai saying that the fibrin glue doesn't work, that would be very good. Thank you.
Thank you, Dr. Hoyman. Dr. Lawrence, you've been with us before, right? Several times.
Yes, I have.
Okay, all right.
When my computer works.
Okay. All right, great. Good
Right. Do you have a question for me?
Ma'am?
Yeah, good to see you too.
Okay, thank you. Good to see you again. Do we have any other? I'm saving the last comment for Dr. Martos to close the session. But before we turn it over to him, does anyone have any final comments? Other final comments? Both old and new, for joining us. We look forward to seeing you again.